Good afternoon, everyone. Welcome to the Christmas Regional Anesthesia School. My name is Dr. Madan Narayanan. I'm a consultant anesthetist from Frimley Park Hospital in United Kingdom. Today, I will be talking about sacral plexus, especially sciatic nerve block. I would like to acknowledge Nysora, the Anso app, and anatomylearning.com for the images. The sacral plexus originates from the ventral rami of L4 to S4. The L4 and L5 together form the lumbosacral trunk. This lumbosacral trunk, along with the S1 to S4 ventral rami, together form the sacral plexus. There are 7 nerves which come out from the sacral plexus, of which the largest nerve is the sciatic nerve. The other nerves which come out from the sacral plexus are the superior gluteal, the inferior gluteal, the nerve to piriformis, nerve to quadratus femoris, obturator internus, and the pudendal nerve. All the nerves emerging from the sacral plexus exit from the pelvis through the greater sciatic foramen. The sciatic nerve emerges from the pelvis and enters the gluteal region posteriorly. So the sciatic nerve emerges through the greater sciatic foramen and travels on the inferior aspect of the piriformis muscle to enter into the gluteal region. The sciatic nerve then travels on top of the superior gemellus, the obturator internus, and the inferior gemellus. As it descends down further, it travels on the dorsal aspect of the quadratus femoris muscle lying between the ischial tuberosity and the greater trochanter. Then the sciatic nerve descends into the posterior aspect of the thigh, sandwiched between the adductor magnus muscle and the long and short head of the biceps femoris muscle. The sciatic nerve then enters into the popliteal region. At the apex of the popliteal fossa, the sciatic nerve divides into a medial tibial component and a lateral common peroneal component, which winds around the neck of the fibula. The sciatic nerve is indicated for any operation on the knee, leg, foot, and the ankle. So in combination with a femoral block or a lumbar plexus or a fascial block, any surgery on the lower limb can be performed. The commonest surgeries are foot and ankle surgery, such as forefoot, midfoot, or hindfoot surgery, and lower limb amputations, especially below knee amputations, where a sciatic block needs to be performed. This image shows the osteotomal, myotomal, and dermatomal supply of the sciatic nerve. So the osteotomal distribution involves the vast majority of the tibia and the fibula, leaving only a small aspect on the medial side of the medial malleolus. The anterior surface of the lateral condyle, as well as the posterior-medial and posterolateral surface of the medial and lateral condyles of the femur, are supplied by the sciatic nerve. Hence, you need to use a sciatic nerve block or a IPAC block for posterior knee pain. All the muscles of the lower leg are completely supplied by the sciatic nerve. And in terms of dermatomal distribution, the whole of the lower leg is supplied by the sciatic nerve, apart from a medial aspect which is covered by the saphenous branch of the femoral nerve. The sciatic nerve can be blocked at 5 different levels. There are the proximal approaches and the distal approaches. The more the proximal approach, additional components of the sacral plexus are blocked, such as the superior gluteal nerve, the inferior gluteal nerve, the nerve to quadratus femoris, piriformis, and obturator internus, and also the posterior femoral cutaneous nerve. It is quite important to know that the inferior gluteal nerve and the nerve to quadratus femoris supplies the posterior capsule of the hip joint. So these blocks may be relevant for hip surgery. So the lower the block is performed, these components are all missed. So the first level at which the block can be done is called as the parasacral sciatic block, where it is done at the level of the sciatic foramen. A variation to this block is called as the parasacral ischial plane block. The second level is at the superior gemellus. It is called as a transgluteal sciatic block. This block is performed lower than the piriformis muscle. The third level is called as the infragluteal block, where the block is performed midway between the ischial tuberosity and the greater trochanter, where the sciatic nerve travels on top of the quadratus femoris muscle. The next level is at the proximal thigh, performed from the anterior aspect, which is called as the anterior sciatic block. And the final level is at the level of the popliteal fossa, which is called as the popliteal sciatic block. So the nerve can be blocked at any of these levels and to achieve a successful block. The first block that we'll discuss about is the parasacral sciatic block. As mentioned before, the sciatic nerve exits the pelvis through the greater sciatic foramen. Initially, it is anterior to the piriformis muscle. It exits on the undersurface of the piriformis muscle. So the key landmark to performing the parasacral sciatic block will be the piriformis muscle. Additional advantages to doing the block at this level includes the blockade of the superior gluteal nerve, the inferior gluteal nerve, and the posterior femoral cutaneous nerve. Pudendal nerve could be blocked as a side effect of this block. A curvilinear probe is placed medial to the midpoint of the posterior superior iliac spine and the greater trochanter. When the probe is placed there, the iliac bone is seen as a continuous hyperechoic line which is covered by the gluteus maximus and the medius muscle. As the probe is moved inferiorly parallel to the lateral edge of the sacrum, the iliac bone shows a defect or an opening, which is the greater sciatic notch. The posterior border of the ischium is seen over here, and medial to it lies the sacral plexus. As the probe is placed in the parasacral region, this is the typical image that is obtained. The structures identified are the sacrum on the medial side, the posterior border of the ischium on the lateral side, the gluteus maximus muscle, the piriformis muscle emerging from deep to the sacrum and coming out superficially, the gluteus minimus muscle, and anterior to the piriformis lies the sacral plexus and the gluteal vessels. The retroperitoneal structures are seen anterior to the sacral plexus. A needle is approached from a lateral to a medial direction to contact the sacral plexus, and an injection of 20 ml of local anesthetic is performed. A modification to the parasacral sciatic block is called as the parasacral ischial plane block, where the injection is made on the medial edge of the ischial bone under the piriformis muscle, and an injection of local anesthetic spreads to the sacral plexus. This is an ultrasound image of a parasacral ischial plane block, which was described by our team, where an injection is made on the medial edge of the ischial bone, and an injection of local anesthetic under the piriformis muscle is made, which surrounds the divisions of the sacral plexus. We performed cadaveric validation studies of the parasacral ischial plane block, where an injection on top of the ischium covers the sciatic nerve as well as the posterior femoral cutaneous nerve. There are many advantages to the parasacral ischial plane block. The bony landmarks are easily visualized on ultrasound and have a consistent relationship with the sacral plexus. The simple fascial plane spread extends medially and consistently blocks the sacral plexus. The needle stays well away from neurovascular structures and hence increases safety. A patient can still have neuromuscular blockade, and as nerve stimulation is not necessary for this fascial plane block, it can be still used on patients who are paralyzed. There's less chance of damage to vessels or surrounding retroperitoneal structures. There are multiple anatomical variations of the sciatic nerve as it emerges on the inferior surface of the piriformis. The sciatic nerve could be branched, it could come through the body of the piriformis, or it could emerge from superior to the piriformis muscle. The sciatic nerve sometimes can be branched right at its origin into the common peroneal and the tibial nerves. So we need to be aware of the anatomical variations in relation to the piriformis muscle. The next approach that we'll discuss is the transgluteal approach. The transgluteal approach is performed inferior to the level of the piriformis muscle at the level of the head of the humerus, where the nerve travels on top of the superior gemellus muscle. This is the typical ultrasound image obtained at the transgluteal level. The bony structures identified are the ischium medially and the head of the femur laterally. The gluteus maximus and the superior gemellus muscle sandwich the sciatic nerve. The inferior gluteal vessels and the pudendal vessels are seen in this plane. A needle is approached from a lateral to a medial direction to contact the sciatic nerve, and an injection of local anesthetic is performed in the plane between the gluteus maximus and the superior gemellus. The next approach that we'll look at is the infragluteal approach. The infragluteal approach is performed at the level of the ischial tuberosity and the greater trochanter. The sciatic nerve travels on top of the quadratus femoris muscle. This level corresponds to the inferior gluteal approach of Raj. This is the typical probe position for performing the infragluteal sciatic block. The probe is placed on the gluteal crease. The patient can be either in the prone position or in the supine position with the hip and the knee flexed at 90 degrees. When the ultrasound probe is placed in the gluteal crease, the typical ultrasound image obtained is as shown. The bony drop-off of the ischial tuberosity on the medial side and the femoral cortex on the lateral side is seen. The muscles which sandwich the sciatic nerve are the gluteus maximus and the quadratus femoris. The sciatic nerve and the posterior femoral cutaneous nerve is seen in the plane sandwiched between the gluteus maximus and the quadratus femoris. The biceps femoris and the tendon of semimembranosus are seen superficial to the sciatic nerve and the posterior femoral cutaneous nerve. The obturator externus is seen deep to the quadratus femoris muscle. This typical image looks like the sciatic nerve is on a hammock stretched between the two trees like the femoral cortex and the ischial tuberosity, and the hammock is stretched between these two landmarks where the sciatic nerve is suspended. A needle is approached from a lateral to a medial direction to make contact with the sciatic nerve and then inject the local anesthetic. The sciatic nerve can also be blocked from an anterior approach from the front of the thigh. The anterior approach to the sciatic block is performed at the level of the proximal thigh, where you could see the sciatic nerve sandwiched between the adductor muscles and the hamstring muscles. So the sciatic nerve lies sandwiched in the intermuscular plane between these two muscles. For performing an anterior approach to the sciatic block, a line is drawn from the anterior superior iliac spine to the pubic tubercle. A second line is drawn parallel from the superior aspect of the greater trochanter to the first line. The junction of the medial third with the middle third, a line drawn from that to intersect the second line, is where the probe should be placed. So the ultrasound probe should be placed at the intersection of these two lines. The typical ultrasound image of an anterior sciatic block shows the bony shadow of the femoral cortex, and medial to this lies the sciatic nerve, which is sandwiched in the plane between the adductor muscles comprising of the adductor longus, brevis and magnus, and the hamstring muscles comprising of the biceps femoris, semitendinosus and semimembranosus. The vascular structures of the superficial and the deep femoral vessels are also identified. A needle is approached from an anterolateral to a posteromedial direction to make contact with the sciatic nerve, and injection of local anesthetic is made. To obtain complete anesthesia of the leg, the adductor canal block can also be performed in the same injection with a single penetration and a dual injection technique to cover complete anesthesia for the leg, and this is called as the SPEDI block, a single penetration dual injection technique which was described by Borglum et al. We will discuss the last and the commonest approach to perform the sciatic block, which is at the level of the popliteal fossa. At the level of the apex of the popliteal fossa, the sciatic nerve typically divides into the medial tibial component and the lateral common peroneal component, which winds around the neck of the fibula. The popliteal block can be performed with the patient in the prone position, lateral position with the side to be blocked uppermost, or in the supine position with the leg bent at 90 degrees. When the ultrasound probe is placed at the apex of the popliteal fossa, the popliteal vessels are identified immediately, the popliteal artery being deeper and the popliteal vein superficial. The tibial and the common peroneal nerves are seen superficial to the popliteal vein. They lie sandwiched between the biceps femoris and the semimembranosus muscle. The popliteal nerves are surrounded by the paraneural sheath of Vloca, and in between the tibial and the common peroneal nerve lies an septum of Compton-Cruvillier. The tibial nerve is seen on the medial side and the common peroneal nerve is seen on the lateral side just underneath the biceps femoris muscle. To perform this block, a needle is introduced from the lateral to medial side just underneath the sciatic nerve superficial to the popliteal vein. The block can also be performed in an out-of-plane approach directly close to the paraneural sheath. A recently described approach to performing the popliteal sciatic block is called as the CAPS block, or the crosswise approach to popliteal sciatic block. This is a supine lateral approach to perform the sciatic block in the distal third of the leg with the patient in the supine position. As the probe is placed on the distal third of the thigh, you'll be able to identify the femoral cortex, the vastus lateralis, and the biceps femoris, with the nerves lying deeper to the biceps femoris. The ultrasound image obtained with the probe placed in the distal thigh on the lateral aspect shows the biceps femoris, the popliteal vessels, and the sciatic nerve lying superficial to it. Needling for the CAPS block can be performed either in the out-of-plane approach or the in-plane approach. So the needle goes through the biceps femoris muscle to enter the paraneural sheath, and here you could see the injection of local anesthetic in the paraneural sheath, separating the common peroneal and the tibial nerves. In summary, the sciatic block can be performed at either the proximal or the distal levels, and there are multiple approaches to performing this block. The proximal level block have the added benefit of blocking the additional components of the sacral plexus, but they come with the additional dangers of being a highly vascular space or being close to vital structures. The parasacral ischial plane block is an easy fascial plane block to the sacral plexus. The distal blocks at the level of the popliteal fossa are easy, safe, and have the greatest applicability. I thank you very much for your attention and I would welcome any questions.